Well, welcome to CAHSPR Talks. This is CAHSPR's flagship webinar series, and we're thrilled to have a really great session for you today. Today's session is Artificial Intelligence in Healthcare and Health Professional Regulation. Our session today is going to be moderated by Dr. Brenda Gamble, and our presenters are Dr. Kathleen Leslie, Dr. Zubin Austin, and Dr. Andréa Foti. So on behalf of CAHSPR, welcome. We are pleased to have you. Make sure that you also check out the other series options on the webinars page. A lot of great content coming your way. So with that, I'm going to hand things over to Dr. Brenda Gamble.
Thank you, Sally. Welcome, everyone. I bring you greetings from the traditional territory of the Mississauga, Anishinaabe, which is made up of Curve Lake First Nation, Alderville First Nation, Hiawatha First Nation, and the Mississaugas of the Schuylkill Island First Nation. May we dedicate ourselves to moving forward in the spirit of partnership, collaboration, and reconciliation as we learn together and contemplate the possibilities that lie ahead. This willingness to partner is important for researchers, educators, and healthcare professionals. The Truth and Reconciliation Commission of Canada calls to action states that there is a need to provide culturally competency training for all healthcare professionals as one strategy to address the trauma caused by colonialism. I invite you to acknowledge the lens you are currently situated on and reflect upon what this means to you and the possible action that can be taken. So welcome, everybody. The approach we're going to take today for the webinar is that each panelist will have 12 minutes to speak, and there will be opportunities for the audience to ask questions at the end of all three presentations. Each panelist will introduce themselves, so I will turn over the webinar to Kathleen Leslie. Kathleen?
Thanks so much, Brenda. I'm just going to get this sharing set up here. Okay, hopefully everybody can see my slides there. Brenda, you want to give me a thumbs up if you're seeing that there? Perfect. Wonderful. Okay, thanks so much. And thanks everyone for joining us for this webinar today. I'm really excited to be joining you today. My name is Kathleen Leslie. Please feel free to call me Kate. I'm an associate professor at Athabasca University, an adjunct prof at Western, and the governance and regulation lead for the Canadian Health Workforce Network that's helping to co-host this webinar today. My background is as a registered nurse and as a lawyer, and I like to combine those backgrounds in my program of research, which focuses on health law and policy, and specifically a lot around professional regulation and health workforce governance. So I'm really excited to kick off the panel today. I'm going to focus on some of our recent research projects around regulating health professionals in a digital age. So to get us started, I've grabbed some headlines. I just did a quick search, looked for headlines and around the past year that would highlight some of the promises around AI and how it can improve health outcomes and how it can improve the work of health practitioners. And as you read some of these headlines, I'd like you to think about how AI could augment the work of these health practitioners, and then where AI starts to potentially replace the judgment of clinicians and where that line falls. So here's a study where AI helped clinicians read x-rays. It did a great job, just as good as the radiologists, and together they were better than either alone. In screening for skin cancer, AI system found here in the study even better than clinicians. In the UK, there's an app that has started providing mental health services to healthcare staff, and it's helping them improve their overall well-being. Another headline, this one from Canada, around how AI is helping to reduce some of the paperwork for providers. So helping fill out all of those forms and write the referral letters and write clinical encounter notes. And then again, here in Canada, we have AI tools that are helping to get patients seen sooner, so reducing wait times for procedures and wait times from in Emerge as well. So what about for regulators? And just a quick refresher here to make sure everybody's on the same page. When we're talking today about professional regulation, we're talking about those bodies that protect the public by regulating individual practitioners. So these are the bodies that set the requirements for entry to practice, keep a register of people who are entitled to practice, set the standards and continuing competence requirements, investigate complaints, and then, if needed, impose sanctions through discipline processes. So regulators are really complex organizations. They have specific legislated functions, and they manage a lot of data. So could AI help regulators be more effective? Again, some more headlines here from just again, recent headlines that could apply to regulatory work. So what about identity verification? Could AI help with that? We already have this happening in Canada within different government organizations for verifying documents and identity. What about predictive analytics? So this, if we could use some of the regulatory data to predict who might be most at risk of misconduct and then target specific educational offerings to them rather than using what a lot of regulators use now, which is the random audit system. And finally, what about writing reasons after a discipline hearing? There's a real art to this, to ensuring that your reasons are fulsome enough for the parties to understand why a panel made a specific decision. Could AI help with that? So just a couple ideas of things that might help regulators using AI. But what about the peril? So this is the other side of the coin, and I think it's really a many-sided coin, but some of the risks of using AI. So first, who's to blame when something goes wrong? So a nurse practitioner is using an AI scribe. Will that scribe be treated as a medical device where the manufacturer has certain responsibilities, or like a trainee, so more like a student nurse under that nurse practitioner's supervision? Then there's automation bias. So this is where people are biased to trust a machine. And AI in particular can write in a way and interact in a way that makes us think that it must be right, even in the face of evidence that it is wrong. And a great example of this, my favorite for any Office fans out there, there's an episode where Michael continues to follow his GPS in his car right into a lake, even with the person beside him yelling, "Stop, you are driving into a lake." But he is trusting the machine. What about the perils for regulators? Again, a few recent headlines. We have the federal court in Canada banning its judges from using AI to make decisions or to help write reasons. Then there's the chat bots. So here's a headline from a National Eating Disorder Association in the US, created a chatbot called Tessa. Tessa was meant to provide resources and information on services for eating disorder treatment, and instead could be prompted to give out weight loss advice. A little closer to home, Air Canada found liable for a chatbot's bad advice. Basically, there was a chatbot on Air Canada's website that told a customer something wrong about a bereavement fare ticket, and then Air Canada refused to provide the fare difference. And the court found that the chatbot was part of Air Canada's website, and Air Canada was responsible for what it said. And my final example here, this was the first case we had when this happened in Canada. There were some cases in the US before this, but a lawyer relying on fake AI-generated cases in legal documents. And the court found in this case that there was no intention to deceive, but that the lawyer was naive about the risks of using ChatGPT and said that it was unfortunate that this lawyer was not aware of the warnings about AI that her regulator had issued already. Okay, so we've got a little bit of a grounding on the current state of AI and its promise and peril in healthcare and regulation. And this leads to a research program. So one pillar of the research that I'm doing right now is looking at the impact of technology on regulation, working with a lot of wonderful colleagues on various projects for this. So we started with 2 SSHRC grants on regulating professionals in virtual practice. And then we've built on these with 2 current projects led by my colleague and research partner, Tracy Adams. The first is looking at regulating ethical challenges that may be changing in the face of technology. That's in Ontario. And then we have a larger pan-Canadian study right now looking at regulating the digital age using a survey and interviews. I want to pull out a couple findings from these studies that are related to AI. The first is around technological competence. So how do you ensure that the registrants and different practitioner groups are technologically competent? Should regulators be requiring specific competence in using technology? This was a question that we tried to assess. We used a few different ways to try to get to this, and this was one area we found no clear consensus. We looked at a content analysis of Ontario health regulators' codes of ethics and standards of practice. We found that 6 out of 26 had statements requiring competence in the use of technology. One example, the College of Psychologists and Behavior Analysts of Ontario requires registrants to be competent in any technology they adopt in practice, know the risks of that technology, make their clients aware of those risks, and ensure that technology is not used in place of their own professional knowledge, skill, and judgment. In our Pan-Canadian survey of regulators, we also found that these types of statements were pretty uncommon, but they were more common in certain fields, like in regulation of legal practitioners. This is much more common. 76% of our survey respondents did not have a standard or policy on technological competence, and a similar number, 74%, had not incorporated tech competence into continuing competence or QA quality assurance requirements. When we talked to regulators, we found that this was generally expressed as a mindset that competence is competence. So here's we had lots of different quotes around this. I've pulled out one quote from our research that, I think competence is competence. That includes communicating effectively, having practice management processes in place effectively, and using technology effectively. I don't personally believe that there is a need for a specific requirement around technological competence. So it doesn't matter what the practitioner is doing in practice, they just need to be competent. In addition to the tech competence piece, I also wanted to pull out a little bit about specifically around AI. So we asked about how regulators were addressing AI use by registrants. Was there guidance around how to use AI? So again, we did that content analysis. We found that, again, 6 out of 26, it was not the same 6, had statements explicitly addressing AI use. So this is an example from the College of Dietitians of Ontario. If dietitians are using AI, the college requires that they apply professional judgment to review the AI output and ensure it's consistent with equity, diversity, and inclusion principles. They must uphold human autonomy and retain decision-making authority. Now, of these 6 that we found, most were published in 2024, and we were looking, just in early to mid 2024. So I expect that these are becoming more common, and we'll probably see even more now that, since we've finished our data collection, there's probably more of these statements. What about the use of AI by regulators themselves? Like some of those ideas I mentioned earlier around the promises of AI that could maybe improve regulation. We asked that again in our survey of regulators, and we found that only 16% believed that AI would make it easier for regulators to govern practice of their registrants. There were some top possible benefits that were mentioned. These were mainly theoretical because, again, not many were actively using AI, but there was improved efficiency, optimizing the use of limited resources were the main benefits we heard about. Top concerns were around reliability and accuracy, this general sense of, we're not even sure how to use this technology appropriately, privacy risks, discrimination or bias, and a lack of human interaction. Again, I've pulled out a couple quotes from our interviews with regulators. AI is a tool that can make your work life much more efficient and do things for you that really artificial means or technology or software can do for you. So you can get more involved in what's important in your day-to-day work. And another quote, I don't think anybody enjoys talking to AI over a person. So while we do move towards digital communication for everything, it's important to make some kind of personal relationship as well. And we heard that this personal relationship was more important in certain aspects of regulation, like around complaints and discipline, matters of incapacity, et cetera. Those were really important to have a human touch. All right, so just a couple quick takeaways we have from our research. We found some examples of more leading practices of being technologically forward. So having really clear guidance for providers around the use of AI. Some regulators were starting what's known as sandboxes. So this is where the regulator creates a safe spot to test out new technologies in practice with regulatory oversight. But there were definitely some things that were making it very hard for regulators to prioritize being technologically innovative. I think our other panelists will be able to speak more to these barriers too. But resource constraints, a big one for sure. Regulatory data silos, so where we have regulatory data systems that can't talk to each other, so they can't make the most use of data analytics. And this really fast pace of change where if you're too prescriptive about something, then it's out of date by the time the ink dries. Another takeaway is that we know assessing competence is a core aspect of professional regulation. And I think if we look into the not too distant future, we can expect that there will be areas of healthcare practice where if you don't use certain technologies that are shown to be better or safer or more accessible, then you might not be considered competent. So how do we address that at a regulatory level? And on the other side, how do we ensure that practitioners know when their use or misuse of AI or other tech could run afoul of the rules of the regulator and lead to an allegation of misconduct? And finally, my last point here is that professional regulation is fundamentally a reactive business. There's a lot of talk about becoming more proactive, but historically regulation has been based on a reactive model, and a lot of the legislation empowering regulators is really old. So regulators are in many ways responding to risks when they're identified and problems arise. And it can be really difficult to anticipate risks associated with AI. It's such a new area. Another element is that regulators often have limited or no authority. There are some exceptions, but over workplaces and employers. And sometimes that's where the ethical challenges are arising in relation to AI or tech use. And finally, regulation is high stakes. I mean, people's livelihoods and the public safety are at stake. So there's, I think, a lower risk tolerance to certain new technology adoption within regulation. I'm going to end here. I would love to connect at any time. I'll put a link in the chat too if people like, but if you have a second device handy or you want to copy down the link tree, you can just take a picture of that QR code. It'll take you to the link tree where I've got the slides for today. I have all my references for all the sources I used, and I've got some links to our academic papers and contact details, etc. Thanks everyone so much. I'm going to pass it now right over to Zubin to continue the conversation.
Okay, thank you very much, Kate, and thank you so much for the opportunity to speak to you about some of the work that I have been doing that sort of parallels some of the work that Kate has been doing, but also has a little bit more of a focus on the role of artificial intelligence in health professions regulation. I am just going to get my slides queued up. So by way of introduction, I am Zubin Austin. I am a professor and the Murray Koffler Research Chair at the Leslie Dan Faculty of Pharmacy and the Institute for Health Policy Management and Evaluation at the Dalla Lana School of Public Health at the University of Toronto. And eerily similar to Kate, I started out life as a pharmacist. Rather than become a lawyer, I went on to complete an MBA and a degree in information science before completing my PhD and now haven't been working at the University of Toronto. In terms of funding disclosures, this is complicated work that is that sort of touches in a lot of different areas, and so funding to support the research presented today comes from a variety of different sources listed here. Most recently, the Network to Improve Health Systems. Kate has done a great job of helping us to understand the promise and peril associated with artificial intelligence technologies. And of course, the problem from a regulatory perspective is that we know AI continues to evolve rapidly, and it's actually capturing both public interest and imagination. Beyond the dystopian scenarios of Skynet, or if you're my age, HAL from 2001: A Space Odyssey, this idea that somehow machines that can outthink human beings starting to become more prevalent is something that we all read about without necessarily understanding how dystopian futures need to be balanced against meaningful and necessary improvements to the healthcare delivery that Canadians have come to rely on. And it's this issue of risk balancing overregulation that could stifle innovation, and underregulation that may generate risks for the public that is top of mind for many regulators. Ignoring this and pretending it doesn't exist or assuming it'll go away is probably as problematic as coming in with such a heavy hand that we actually stifle creativity, productivity, and innovation that could actually have some meaningful and valuable impacts for our healthcare system. William Shakespeare said that there is nothing either good or bad, but thinking makes it so. And so my perspective as a researcher in this is not to come into it from a perspective of being a cheerleader or a booster for AI, nor come into it assuming the sky is falling and the worst catastrophes are going to happen, but instead try to think about principles such as responsible, proportionate, ethical, and equitable application of AI technologies so that as many Canadians as possible can benefit from it. The work that we have done to date in this area has surfaced two major schools of thought around how AI tools in health professions practice can or should be regulated. The first is the distinction between regulation versus guidance, and the second is the use of principles versus rules. As we think about the role that regulators play, it's important to recognize that regulation as a tool is a pretty blunt instrument. As you all know who are regulators, it takes a lot of time, a lot of consultation, and a lot of work to actually carefully craft regulation. And there is a weight to regulation that is important. Regulations do not come and go like the wind. Once regulations are in place, they're enormously challenging to undo or replace. And so when we use a weighty instrument like regulation to govern a fast evolving kind of practice like artificial intelligence, we may not be using the right tool for the job. And so in the literature and in key informant interviews with regulators globally, an evolving theme has been that it may be too soon to consider use of regulation, but it may be the right time to start to talk about guidance. Guidance has more of a voluntary connotation to it. Guidance has more of an educational role associated with it than regulation. The main issues that both the literature and regulators tell us is that we are at a state currently of AI evolution where the distinction between HOL and HIL AI is not clear. The acronym HOL stands for human out of the loop, and the acronym HIL stands for human in the loop. And what it refers to is who ultimately has decision-making control of the artificial intelligence technology being used. Currently, the vast majority of AI tools are HIL, human in the loop. AI supports, advises, finds ways of coalescing literature, directs human practitioners in certain ways. But the ultimate decision-making authority still rests with the human professional. As Kate pointed out, several regulatory bodies are trying to codify this in either their standards of practice or codes of ethics, that you need to know how to use AI, but still the human professional always has to retain final decision-making control. The vast majority of AI today is of the HIL variety. But from an organizational perspective, from an efficiency and cost effectiveness perspective, where the direction of travel is clearly moving is towards human out of the loop AI. The idea that you can save money and improve operational efficiencies in organizations if you actually allow AI to make decisions autonomously. And as that day starts to dawn, the complications of relying on guidance versus regulation will increase consistently. Regulators also tell us that they have sufficient confidence in existing regulatory processes outside of licensing bodies. This includes things like professional standards association, the use of civil lawsuits or tort law processes to make sure that tech companies stay in line, the use of national standards or institutional accreditation bodies focused on workplaces, or the use of federal or national legislation. One of the risks of relying on all of these other practices, of course, is what we have seen with social media over the last decade. By now, we all know that basically Facebook is too big to control. Meta is too big to control. Even the American government can't control it. And the idea that we can leave regulation of AI in healthcare to other kinds of processes is undermined by the experience of what's happened with social media in our lifetime. And it starts to raise questions of where do licensing and regulatory bodies actually fit. Currently, what our research points to is the strong preference of regulators themselves to opt for guidance versus regulation, so long as human in the loop AI predominates. The second major finding of our research has been the adoption of principles versus rules. Principles-based regulation is much less prescriptive and much less assessment oriented, but instead tries to empower individual practitioners to understand what are the key guiding principles that should undergird their use of AI in practice. We've thus far identified these principles, and I'll go through them very quickly to give you a sense of the direction of travel in this work. The first core principle is one of disclosure, that when AI is being used, either human in the loop or out of the loop, patients need to be aware. Disclosure is simply defined as the act of making something known, and there's a broad variety of literatures that focus on different types of disclosure, but the principle here is that AI should not be used to support human decision-making or replace human decision-making unless this is actually disclosed to the person receiving care. Importantly, in this literature, there's a distinction between disclosure and consent. In law, these are not the same thing. Simply disclosing without actually actively getting consent from a patient to use AI-enabled tools, whether they're human in the loop or human out of the loop, is an important distinction to keep clear. Part of this also involves concepts that we take for granted, such as implied consent or consent by action. But the second key principle that's surfaced in our work has been the importance of disclosure plus consent, and not assuming that disclosure by itself is sufficient. The third key principle that has evolved is one of transparency and openness. All healthcare professions have an ethical imperative to be transparent and open, and that involves whether you're working with or without AI. This simply means that we need to work or provide care in a manner that makes it easy for all others to see what actions are being performed and undertaken and why, and involves a variety of clear, constant, consistent verbal and nonverbal communication techniques. How transparency and openness actually occurs with the black box, that is AI, is a very important question. Few, if any, healthcare professionals, me included, have any idea how the technologies we use actually work. We have implicit faith that, yeah, somebody must know what's going on here. I just use the outputs. I don't understand the processes. And what makes this principle very challenging to action is the technology itself is so opaque and so resistant to openness. How on earth can the practitioners using this actually fulfill this principle? More work in this area is certainly needed to understand this. A fourth principle that has surfaced from our work is the notion of choice. The idea, and this builds from disclosure and consent, that patients need to be provided with options and actually choose AI if it is going to replace a human, or accept and choose that AI is going to be supporting human in the loop care that's being provided. This choice needs to be free with no consequence or cost for patients or caregiver, and it must be informed. A fifth interesting principle that has emerged is one of redundancy. A few months ago, many of you may remember where there was some software program that crashed and the entire world came to a standstill. One of the major concerns about AI in health professionals' work, or AI in the workforce in general, is mass de-skilling of the professional workforce. Think about it with your own children, for example. There is no child under the age of 15 today who is capable of doing mental arithmetic. No child under the age of 15 can go to a grocery store and estimate how much sales tax must be paid, or how much money they need to spend for a bucket for a trolley full of food. We have de-skilled as a society in general around mental arithmetic. And the concern is, even with human in the loop artificial intelligence, that as we become more reliant as professionals on using AI, de-skilling is going to occur. In this environment, when system breakdowns and technology failures occur, will humans be able to work around the system any longer? Redundancy is an important principle where AI starts to become more involved in day-to-day care. Ensuring that manual or non-AI enabled systems still can allow for the provision of care is an essential part of ensuring responsible adoption in workplaces. A sixth principle that has emerged is audit and feedback. Audit and feedback involves multi-source information to confirm safety, quality, efficiency, and cost effectiveness of value of AI. Quality assurance mechanisms are part of this, but it really is about monitoring what is happening with the AI to ensure that small problems do not become big problems. And it's on the basis of audit and feedback that quality improvements in assurance emerges as our seventh core principle for adoption of AI. We know that there are major concerns regarding the codification of system bias when AI gets used. And while use of audit and feedback mechanisms can help us to figure out where there may be some risk of these kinds of system biases, we want to ensure that AI is actually improving practice of individual practitioners. The eighth principle that has surfaced in our work is that whether or not it's human in the loop or human out of the loop AI that is being used in healthcare delivery, everything needs to adhere to codes of ethics. As regulators are aware, there is a complex interplay between standards of practice and the codes of ethics which govern the conduct and behavior of practitioners. And the actions and reasons behind the actions and the reasons behind actions are of vital interest to regulators. The way in which we understand ethical behavior of AI, whether it's human in the loop or human out of the loop, is another area of evolving interest. But the idea that AI needs to conform to existing codes of ethics is an important principle that is emerging. The final principle in our work that has surfaced is one that's much more technical in its orientation, and that is the concept of interoperability. As many of us know, over-reliance on single vendors or platforms can lead to something called regulatory capture. When there is only one vendor of an artificial intelligence or technology platform, there is substantial risk to patients. Interoperability of systems is important to ensure continuity of care and service in the event of technological breakdown, but also to reduce risks of monopolistic controls of practices or professions. As AI becomes more advanced, it is essential to ensure that systems are interoperable, that there are plan Bs, and that there are actually other vendors who can compete to ensure we don't end up with monopolies that can end up having distorted influences and impacts on care and on the practice of professions. What all this work points to is that timing is crucial. It's likely too soon to think of regulation broadly as a tool regulators need to embrace in order to control AI. As Kate pointed out, regulation tends to be more reactive. And since currently most of the AI we're working on is focused on human in the loop, regulating the professionals that use AI should be sufficient. But this is going to change quickly, and anticipating this change is going to be something all of us will need to be concerned about. And so in summary, and before I hand it over to Andréa, planning for regulation is essential even if it's not yet time for it. The reality is we have a patchwork today, everything from civil lawsuits to federal legislation to professional standards associations to accreditation bodies for hospitals, and we all need to work together in order to see how we're able to best manage, not over-regulate, but not under-regulate AI. Licensing bodies have incredibly unique and complementary roles and responsibilities, and it is leveraging that complementarity that is going to be incredibly important. Ultimately, what we all need is proportionate regulation necessary to ensure innovation can thrive and public interests are safeguarded. Thank you for your attention, and let me turn it over to Andréa for her presentation.
Great, thank you so much, Zubin. And hi, everybody. Great to be with you today. I'm Andréa Foti. I am the Deputy Registrar and Privacy Officer at the Royal College of Dental Surgeons of Ontario. And so I'm going to be trying to offer some comments through what does AI guidance regulation look like from a regulatory perspective. So if I could just have the next slide, please. Just a few disclosures here. I'm not going to make comments from a tech perspective. My background's in law, policy, and privacy. You'll hear me talk about in the subsequent slides. My organization doesn't yet have AI guidance. It's something we're working on. So today I'm not talking to you about a document that's already formed. These are some of my own thoughts about, I think, where we're going to go. So one more click, actually, if you don't mind. I wanted to start with just a tiny bit of background, and thanks to Kate, I'm going to be able to kind of move through that quickly, but I wanted to orient the audience to, I think, the unique perspective of professional regulators in this space. And then I'm going to move through some key issues and sort of touch on those. Again, always thinking about what would we do and say about these issues from a regulatory perspective. So if we get the next slide. These are the three areas I'm going to touch on for context, and just one more slide, please. To start with, Kate touched on generally what are regulators and what type of work do we do. The organization I work for, the Royal College of Dental Surgeons of Ontario, we're the regulatory agency for dentists in Ontario. There's a broad range of work that we do as regulators. I think the main thing, two main things to take away, because this will sort of be woven through my talk. The first is that a key area of work that we engage in is the development of standards of practice for the profession. The other key thing is that I think, in my view, what makes regulators unique is we have a legislative requirement to do our work in the public interest. So everything that we work on when we're compiling guidance for the profession, standards of practice, we're doing so with a lens of what would be in the public's interest. How do we guide the profession to really ensure the public interest is being served? And just one more click, if you don't mind. As I said, our work on AI is in its infancy. And when I talk about AI, I should say, when I talk about AI from a regulatory perspective, I'm really talking about how do we guide the profession in its use of AI. I'm not today going to talk about whether we as an organization will use AI to fulfill our functions. This is about, and my focus today will be on, how do we begin to set some guardrails and guideposts for the profession if it chooses to use AI. So we have started to look into this issue. We launched a consultation with the profession, the public, and system partners earlier this year. We're gathering that feedback and using it together with lit reviews, legal research, and other work to really put together a resource document for the profession. As Zubin said, our focus, I think, to date, and it won't remain static, I am wagering, but our focus to date at this stage will be provide some guidance, but this will likely have to be a stepwise approach where we see and probably come back to anything we produce fairly on a fairly tight interval because things are moving so quickly. Next slide, please. Just for interest, I won't read all of this, but just wanted to sort of anchor you to what does dentistry look like in Ontario right now. Couple things I want you to take away from what's in the gray box. Dentistry, unlike some other health professions, is largely privately funded. So the majority of dentistry takes place in clinics, some in hospitals, but the majority in clinics. Majority is funded by private insurance policies, like what you would get through your employer. Some is public, and we know this from the government's latest significant investment in the Canadian Dental Healthcare Plan. The other point is most of dentistry takes place in clinics, and most of those are owned either by a clinician, and more recently we're seeing clinics being owned by corporations. And I'll come back to those 2 points in a minute. One more click, if you don't mind. What do we know about AI use so far in dentistry? It is being used for a range of different types of tasks, and that's the first bullet in the black box there. The rate or extent of AI adoption at this point is unclear. What we know so far is that we believe AI adoption is going to vary significantly by practice model, where we're anticipating that what we'll see is the larger clinics will start to experiment and are starting to experiment with AI, and clinics that are owned by corporate owners. Next slide, please. So in terms of, what are those key issues? What am I going to be delving into in terms of actual sort of concrete topics? If you could click one more time, there's 4 areas that I want to touch on, and I'll go through each of these fairly quickly so we can move to the question period. But if you could move to the next slide, please. So AI adoption versus this concept called standard of care. Some of you in the audience may know what I mean by standard of care. AI adoption currently is optional. So we're seeing it being used by so-called early adopters who are looking to experiment with this technology. If you could do one more click for me, and then one more again. Great. Contrast that with the legal concept of standard of care. I've really given you a simplified kind of capture of that term here in the blue box. This is a term some of you may know that's used in negligence law, tort law. Generally, the shorthand that gets applied to this term, standard of care, is accepted, general, or reasonable practice. When something becomes the standard of care, it's something then you expect to be used consistently. And in some instances, regulators may insist, and the courts may insist on it being used. Today, we're not nearly at the stage where AI is a standard of care. So I think in the sort of bubbles at the bottom of the screen are some questions and observations that I think we have to ask as regulators if we're looking to guide the profession. So if AI is a choice, what drives the choice? We know, and Kate covered this, and Zubin pointed to it, there are many different reasons why people may choose to use AI in the provision of healthcare. Some of that could be driven for business reasons, efficiencies that they may find, and some may find the attraction of enhanced clinical care ability, as Kate captured in her headlines, looking at radiology screens, etc. That could be appealing. The reason behind the choice, I think, is relevant for regulators to understand and perhaps guide the profession on. When will something become the standard of care? I think we know it's not the standard of care now. AI is not the standard of care, but maybe it will become so in the future. And that's something we'll have to watch for. Do things shift and change in terms of the guidance we offer when something becomes standard of care? Always a question is, what's the impact on patients? So does the impact shift when it's sort of early adoption, it's a choice versus standard of care? How do we determine and ensure that patient interests are protected? Next slide, please. Practice models, and this is tied with AI adoption. I said a bit earlier that we expect and are anticipating, and certainly our working assumption is that adoption varies with practice model. One more click, if you don't mind. I think some of the things that I'm musing about, certainly if we accept this assumption, that there's some unique equity challenges that can be posed where you have those patients who attend clinics where AI use is in play to some degree, enjoy some of the benefits that AI, the promise of AI that Kate touched upon, but also the perils that AI that Kate also touched upon, and that I think we know and we're discovering. Another concern, and I think this was touched on by both Zubin and Kate, where does that autonomy of the clinician lie? does the clinician get to make the decision about whether to adopt AI? Or if we're talking about practice models, is that decision being made by a practice owner to say you must use it, this practice uses it? And what in turn does that do from a regulatory perspective in terms of addressing, assessing that use of AI? Our jurisdiction legally is over our registrants, not over practice owners and not over technology. I think lastly on this point is this legal concept of fiduciary duty. And if that's not a familiar concept to the audience, put simply, this concept of, you know, owing a sense of loyalty, building a sense of trust, putting patients' best interests before the clinician's interests. How is that delivered upon in this model, where AI may be used for different reasons? How do we ensure that that duty is still fulfilled? Next slide, please. Consent. I think this is such an interesting one, and Zubin touched on this. You know, from my perspective, if we think about consent and what does it do and its role in AI use, I think certainly in law to date, it's well established that there are requirements to authorize consent to treatment. So treatment is authorized via consent. We also see consent being applied for information privacy. So there's a comprehensive model in our privacy legislation. If you do one more click, if you don't mind, we don't tend to see typically consent being applied for how treatment is provided, the specific modalities of treatment. Now, it could be that some argue maybe the modality is so integrated into the treatment itself that it becomes part of that consent process. But it's just an observation of mine in terms of how do we think about consent. One more click, if you don't mind. And I think importantly, and I'll sort of go directly into the black sort of bubble here, what is the consent for? If we are to use consent and we're looking for patients to sort of authorize AI use, is it for the treatment that will be provided or the assistance that will be provided to the clinician? Is it for privacy, the risks that may come through AI use by patient information being accessed by AI? Is it about, are we talking about consent for sort of completely autonomous decision-making? That's more problematic for me. You'll see in the next slide, I'll talk about accountability. What does, oh, sorry, if you could go back. What is the impact or relationship of consent to professional accountability? And I raise this because sometimes you do hear in practice of consent almost being spoken of as a way of absolving the individuals involved, the clinicians involved, from responsibility. The patient consented, the patient assumed those risks. And I think lastly in the blue bottle, what would a consent model look like for AI use? You know, when we think about consent, it's typically about empowering the patient or their substitute decision maker to make informed decisions. With AI evolving so quickly, the risks evolving so quickly, the benefits evolving so quickly, is that attainable? Is it accessible for the average patient to really understand those risks, those perils, and those promises? Next slide, please. I think importantly, this notion of professional autonomy and accountability is something that really is prominent in at least the conversations I've had to date with some regulatory colleagues. What would be the role of AI in care? If we acknowledge that AI has a role in healthcare, what's the relationship to the care provider? And Zubin touched on this notion of human in the loop, human out of the loop. You heard me say that our legal jurisdiction as regulators is to registrants. It's to those humans who are providing the care. It's not to another entity. If you click one more time. So I think from a regulatory perspective, insisting on professional autonomy will be vital. That's the way that we can ensure and if necessary, exert some control over the conduct of the registrant and hopefully influence the outcome to the benefit of the patient. The importance of trust and the fiduciary duty, I touched on this earlier, but it's so central to that care relationship. And I think from our perspective, if we imagine getting a complaint about AI use, we need to be able to establish a clear line of accountability back to our registrant. So again, these are some things that I think we would be thinking on and insist on, at least in some of the early stages of our guidance. Next slide. If you could just click one more time. I set out here some questions that I think, we're going to be continuing to think about. Certainly the work that we're going to be engaging in to develop some initial guidance for dentists, it won't be the last. I think this is a document and an issue we'll come back to again and again. I know there's a number of policy people on the line. This is such a unique policy challenge. How do you try to provide guidance on an issue that is moving so quickly, where we know that ethical frameworks and legal frameworks are still coming in, they're yet to be solidified. And I think lastly, in the last gray box here, an interesting kind of question about what role should guidance fulfill? Does AI require a brand new set of rules? Do we exceptionalize it and say, okay, there's a whole new set of rules that we need to put in place to guide professions? Or do we need to anchor to some existing rules, like around consent, if we end up using that, privacy, confidentiality? Is there a combination? And will that change over time? So these are some of the questions we're going to try to answer as our guidance comes in. And I'll leave it there and look forward to some questions. Thank you so much.
Okay, thank you very much, Kate, Zubin, and Andréa, for wonderful presentations. We can move into the question period now. Please raise your hand or put your question in the chat, and we'd be happy to answer your questions. Mary Barton has put something into the chat. Isn't humans out of the loop already happening with chat boot mental health support, chat boot health advice? What role is regulation playing in protecting the public from risk here? Good question. Would anybody like to tackle that question?
So I think you've nailed it on the head, Mary. The reality is things are evolving quite rapidly already and in a somewhat unregulated kind of way. And when technology is working outside of human control, right now the chatbots you refer to, and I don't know them in a sufficient detail to knowledgeably comment on it, but if it's providing care that a human normally would, but there's no human involved in it, it actually means the public protection is only being, it's not regulators that are actually protecting the public. A patient that is harmed could sue a technology manufacturer, could appeal to a manufacturer standards association, or could write a letter to an MP demanding that legislation be invoked. But currently, this is a gap, and I think this is one of the things that's perhaps adding some urgency to it, that it's happening pretty quickly already.
Thank you, Zubin. We have other questions from the audience? While we wait for more questions, something I was wondering about during the presentations. Providers are not going to be the only ones using AI, so are patients. So what happens to that interface, and how will that impact regulation and the provider-client interface? We already know that patients and clients are already armed with lots of information. This kind of adds to their ability to get access to more, which is not a bad thing, but it's something that has managed at the provider-client level.
Yeah, and I mean, maybe I'll just offer some thoughts. Like, what occurs to me, Brenda, and it's a great point, is that there's a significant role there where I think the clinicians can assist in trying to make sure that patients are getting accurate information. If they're going off and seeking out AI to learn about things and to come to their practitioner, it's not necessarily a bad thing. It could spark some good conversation. But I think, to me, the most immediate thing that jumps out is trying to ensure that the patient is working from a place of accuracy and knowledge. And that's where that communication with the practitioner can assist. But it can get pretty complicated pretty quickly if the patient is under a misunderstanding because of maybe some problematic information that they've attained. But maybe others have different thoughts they want to contribute.
Yeah, I'll just add, I think that's a big point. We were hearing that in some of our interviews and focus groups with clinicians, that they were finding that their clients were coming into them with already some ideas, which, I mean, you can get on Google too, right? Like, you've got Google, and then now you've added that you could maybe ask a generative AI to synthesize some of that information. So, is it a big step? Is it much different? But we were hearing that a lot, that there was just a sort of added level of knowledge that clients were coming to their clinicians already armed with, in terms of having used an app to take pictures of a mole, and to already have an idea of if there's a concern. And so this is why they've made appointments. And what we were hearing is that clinicians wanted to ensure that there wasn't an over-reliance on advice that would be detrimental to those people coming and seeking necessary services. That advice that, oh, that's not a problematic mole, or that there's no, you have no concerns, you need mental health services. This, that those types of advice, that wasn't being relied upon. But there wasn't a really big concern that they were getting more information to help seek services. They just didn't want to have people not seek services when needed. So that's what we were hearing.
But if I could actually,
I'm sorry,
if I
Zubin,
just add
go
that,
ahead.
I think it's actually really important to recognize that. So far we sort of couched it in, I think, fairly generous language, but the reality, I think, is that for governments, for large employers, etc., what they actually see is an enormous opportunity to save money by replacing large numbers potentially of the human workforce. Already we suffer from enormous skill shortages across most professions in this country. There's no feasible way we're probably going to get all of the people that we need. And the for-profit motivation, or the cost minimization motivation to start to shift to human out of the loop AI, or if humans are in the loop, it's in the most notional and remote way, is something I think we're all going to really struggle with, because it means that there are incentives on the part of governments and large organizations, many of them not for profit, that are perhaps at odds with some of the purer motivations that we may be discussing here. And I don't know how we start to reconcile that, but I think we have to reconcile that.
Thank you, Zubin. Unfortunately, we don't have much time for more questions. I will read one more, though, from Wendy. I am curious, from a legal perspective, if the bot developer were to put a disclaimer highlighting the lack of human/clinician oversight, I assume that would likely limit their responsibility, which is terrifying from a literacy/health literacy lens.
Yeah, I mean, I agree. I guess the question would be, does that disclaimer absolve them from liability? I mean, I think that I don't know if that's been tested, and I think there'd be more to come there. But is there a danger there? Is there a risk there? Yeah, I mean, I think it sounds concerning. I agree with Wendy. I think also, just briefly, it ties back to my concerns about if consent is used to sort of in that type of interface, does it then have the effect of depriving that patient from seeking recourse if things go wrong? That's where I start to get worried. And Zubin, I think your point was a good one, where, different people will come to these issues with different motivations and different sort of angles, and how do we apply a sense of reasonableness, fairness, and justice to this? That's where my mind goes.
I think the other thing from a regulatory perspective on this point is what happens when some technologies, AI enabled, are actually performing controlled acts. In Ontario especially, we actually have a very strict and long-standing definition of controlled acts that are the purview of specific people, but we're not too far off from the point when technology can perform a controlled act. Then what happens? And how do regulators actually regulate a non-human performing a controlled act?
Thank you, Zubin. We've run out of time, so I'm going to close off the webinar. The CAHSPR Health Workforce Theme Group and the Canadian Health Workforce Network was pleased to co-sponsor and bring this important topic to CAHSPR Talks. I would like to extend a big thank you to Kate, Zubin, and Andréa for informative presentations on a very timely topic. Also, I'd like to thank everyone who joined the webinar today. Take care, everybody. Bye.